You're listening to the UBC Medicine Learning Network.
You're listening to Metamorphosis, a podcast designed to help medical students navigate their medical careers. Today's episode is another installment of our resident series, where we're interviewing residents with the aim of learning about their path to residency and the specialty they ended up pursuing. My name is Adam.
And my name is Aidan. On today's episode, we will be chatting with Dr. Alexa Mordhorst, a first-year vascular surgery resident out at UBC and the founder of clinicalanatomy.ca. Thank you so much for joining us on the show today, Alexa.
Oh, thank you guys for having me.
Now, for people like my time crunch co-host Adam, who haven't yet been in an OR and don't know what vascular surgery is, how would you describe it?
Pretty much the best surgical subspecialty on the planet is how I would start to describe it. But more realistically, vascular surgery is the surgery done on every aspect of the circulatory system. So we work on arteries and veins. Classically, although it does vary from institution to institution, pretty much anything outside of the heart that's a blood vessel we will operate on. So we're from the neck to the tip of the toes. And yeah, we deal with all kinds of stuff, whether it's venous pathology, whether it's arterial aneurysms, arterial occlusions requiring bypasses, acutely ischemic limbs, anything that involves any segment of the vascular system, that's what we operate on.
Cool. Thank you for opening my eyes to that.
Yeah, I can confirm that definitely helped me out.
Before we get into how you ended up deciding on vascular surgery, I want to take you all the way back to your decision to pursue medicine. Was this something that was always on your radar?
Yes, but for reasons I don't know why. Nobody in my family is in medicine or surgery, but from a super young age, like literally 5 years old, I just was obsessed with becoming a surgeon, not a doctor, a surgeon. Very, very specific. Yeah, it's always been on my radar. I think like growing up, my grandparents, I guess, were in the hospital quite a bit. So we were sort of exposed to the hospital atmosphere. But it's super interesting. Like my sister grew up hating anything that was related to medicine at all. But I just grew up with only the focus of getting to med school and becoming a surgeon as my only goal. So yeah, it's been on my radar for a little bit.
So something you've told us in the past is that you have a background in the performing arts. I was wondering if you could just talk a little bit about that because it's such a unique background to have going into medicine.
Yeah, performing arts was my entire life outside of school. From a super young age, both my sister and I were super competitive dancers. And then just when I got a little bit older, found out that I was, sort of okay at singing. So my life kind of took a bit of a musical theater route. But yeah, that was pretty much my entire life. And a lot of my friends took it sort of professionally and made it their career. And there was a very small segment of my life when I thought, maybe this is what I want to do. That lasted maybe 2 days. And then I went back onto that medical school train. But I still love the performing arts. If I can't, it's kind of hard to be involved in shows. And I've certainly not been as active in that world as I would love to. But I love, even being a consumer of anything musical, creative, performance-wise. I love it. So yeah, it's a huge outlet for me.
Well, I would love to ask you for a sample of your singing voice, but
never in 100 years.
I won't put you through that. Is that something you'd be able to maintain while you're doing medicine and doing your residency?
It's been hard. Like I think growing up and just being at a level that took up, hours of my day every day, 6 or 7 days a week, and being used to that level, coming into even undergrad, like I took a bit of a step down and, I was involved in musical and performance arts clubs, but academics was first. And then coming to med school, I had no idea what to expect coming to med school, and I was absolutely terrified. So that took a hard backseat. Right. But I still managed to, even if it's just coming home and listening to music or whatever. I was part of the jazz interest group and things like
cool.
that. I've always tried to maintain some aspect of it in my life, but it certainly has been a way, way, way backseat at this point in time, especially with residency. But I'm happy just singing in the shower or singing in the car.
You ever sing in the OR?
Yeah, because we play a lot of music,
Nice.
so I definitely do.
Nice.
Quietly, though, under the mask.
More just like humming under the mask.
Yeah.
Oh, that's great. Yeah, that's awesome. Thanks for sharing that. And that's a pretty exciting background, and seems like a pretty interesting path that led you into medical school. But when you came into medical school, did you have a pretty good idea, or absolutely none at all, of what specialty you might want to do?
Yeah, so I was really obsessed with plastic surgery from that age 5. Very specifically, I wanted to be a plastic surgeon. My parents still have evidence of our grade 1 time capsule thing that we opened at graduation that I want to be a plastic surgeon. And I don't know why. So yeah, coming into med school, I was very dead set on becoming a plastic surgeon. But I was aware that this decision had absolutely no foundation. It's not like I knew any plastic surgeons or had shadowed anything. I had no idea where it came from, probably just from watching a lot of TV. So I tried to sample a lot of areas of medicine just to make sure I was certain of the path I wanted to choose. I tried to shadow as much as I could, as many specialties as I could, and just get as much exposure as I could. And I think that's really important to sort of in the earlier years of medical school, because you have such a limited amount of time to choose your path. But I think the first decision is always, is it going to be surgery or is it not going to be surgery? Because they're very different paths to take. And I was very confident from sort of the get-go of med school that surgery is what I wanted to do. I mean, at that point, I was very confident it was plastics, but I was still open to the idea that it might not be. But I knew that it was going to be something surgical. That's what I would want. So,
Right. I'm curious if you ever had a moment in medical school where you maybe doubted is surgery the right place? Like, did you have a rotation in a medical specialty where you're like, oh, you know what? This is pretty interesting.
Yeah, I did. It wasn't medicine, but it was psych. I thought psych was really interesting. It was second year clin skills who did psych, and I just loved our preceptor and our teacher. She was incredible. So I shadowed her, and I found psych very interesting, really interesting. And I think the skills you learn in psychiatry are super applicable to other areas of medicine. I mean, psychiatry is all about listening to your patients and being a really good communicator, and that's transferable to anything you do. So, I really did like psych, and I think I could have seen myself possibly doing psychiatry, but I knew that deep down I'd really miss the environment of the OR. But yeah, psych was a possible contender. Yeah, for a short while.
Yeah, you have your mind open a little bit, right? You can't make that decision.
No, but you have a good point. It's really important to have an open mind, because you don't know what's going to surprise you. And there's a lot of stories of my friends who, were dead set on surgery and switched, or were 100% confident they could never want surgery ever, and then through clerkship were exposed to the OR and changed their mind. So I think going through med school, you really have to maintain an open mind, and you have to be honest with yourself. For sure. Yeah,
which can be tough sometimes, I find.
It's true. It's very true. Because you kind of go through med school with this agenda, and, you kind of listen to what other people say, and you want to follow that status quo and that train of thought. But at the end of the day, it's you, it's your life, and it's your career, and you have to be true to yourself and what makes you happy.
Yeah, of course. Now, one thing, I know obviously it wasn't what you ended up staying in, but could you give us a quick overview of what plastics actually looks like and what it was about that drew you in the first place?
I can try. I didn't do too much plastics afterwards. So what drew me into it initially, like I said, I have no idea. I was a crazy 5-year-old, and I don't even think I knew how to spell plastic surgery. So absolutely no idea what drew me into it. But, coming into med school, I obviously shadowed plastics a fair amount. And plastics was just fascinating. I think you always have to be creative as a doctor, no matter what you do. But plastic surgery, the parts that I saw at least, the staff and the residents, you have to have a very artistic eye, very attentive to detail, but that's sort of across the board in medicine. But with things like plastics, you're often working on someone's face, you're reconstructing various areas of the body, they do foot reconstructions, hand reconstructions, facial reconstructions, body wall deformity reconstructions, patients who have severe burns, even something as what sounds as simple as a skin graft, you really have to think about how you place the skin graft on the body. How's it going to heal? What do the seams look like? I thought plastics was very interesting that way, in the sense you do get to be quite artistic. And, the interactions that I saw with patients, often, times it was the face that I saw. Oh, yeah. And I can't think of anything more important than your face, right? That's what everybody sees, and it's a huge source of insecurity when there's been trauma or burns or whatnot. So to have that connection with a patient when you're working on sort of one of the most vulnerable areas for a person is incredible. And I think the creativity that they have is sensational, and their skill and sort of variability in skill is outstanding. Like they work everywhere. One of the residents once said to me, and it always resonated to me, she said, the plastic surgeon is the general surgeon's general surgeon. They have to be able to do everything. I mean, obviously they're not going to do bowel reconstructions or things like that, but everything else in the body, they have to understand. You need to know the anatomy, you need to know the nerves, you need to know the blood supply everywhere, because you don't know what you're going to be dealing with in plastics. And I thought that was remarkable for plastics, but just wasn't what I ultimately wanted to do.
No, of course. That's pretty impressive. But what was it for you that ultimately led you to change your mind into vascular?
Yeah, that's the money question. So in clerkship, you'll get your surgery block, and then within that surgery block, you have two. Maybe they might change it now, but at my time, you had two surgical subspecialties you were given, and it's sort of a lottery. You just rank them, and I was given plastics, which is the one I wanted, and then I didn't really care what else I had, because I just wanted plastics at that time when I did my rank list, and I was just put into vascular, and I had absolutely no clue what vascular surgery was. Never shadowed it. I've never heard of it. I had no idea what it was. So when I started, it was, cool. Like, I really liked the people. The first couple of days in the service were really nice. Everyone was really helpful. Saw a lot of cool surgeries. One of the days we got to go into the hybrid OR, which is this incredible OR in VGH. And it's just got this huge C-arm, and the lights are all dimmed. And it's like a scene from a movie. And one of the staff was playing Coldplay. No way. And I was like, what is happening? Like, I actually felt like I was in a TV set. It was unbelievable. And that day was a really important day for me. Like, I remember that was my first endovascular case that I had seen, and they were repairing an aneurysm endovascularly. So no big abdominal cuts, just complete reconstruction and repair of the abdominal aorta and curing or treating an abdominal aneurysm. And seeing the body sort of underneath the C-arm, it's projected on this ginormous TV screen in the OR, which is also really cool. Seeing the anatomy in that way, and looking how the body moved under the C-arm, and just the angle, and you see this magical device just spontaneously, at least that's what I thought at the time, like spontaneously deploy and perfectly inside the aorta, and just perfectly exclude this aneurysm and just treat it. And the whole thing is through 2 needle pokes in the groin. Like, that's just, that blew my mind. Like, it actually blew my mind. I couldn't believe what I was seeing. And that was the first thing that really piqued my interest. Like, wow, I've just never seen something like this, like such a crossroads between technology, engineering, medicine, and science. Like, I'd never seen something like that. Yeah. And then within the same day, they did a humongous bypass for this ischemic lower leg, and it was just the biggest incision I'd ever seen. This entire guy's leg was just fully cut open. Wow. Tons of sewing, lots of meticulous work. And I got like the residents let me get my hands in there and help sew up the leg. It was one of the most exciting days of my life. Yeah. And I remember thinking, whoa, this is pretty cool. But not cool enough for me to just, ditch my years of love for plastics for. But after that 2-week rotation, it had been the first time in med school something had piqued my interest as much as plastics had after all the shadowing I did. But it wasn't an easy decision. Like, it just took a long time for me to come to that conclusion. And I had to really think about what I liked about plastics, what I liked about vascular, and what I did not like about each of them. And thinking about my life in the future, what are the things I didn't like that I'd be okay with? Right. And why did I not like certain aspects of plastics? Why did I not like certain aspects of vascular? And just a lot of internal conversations and, weighing pros and cons of both. But ultimately for me, I mean, a lot of things went into that decision, but I think a big thing for me was being honest with myself, just coming back to that thing we were talking earlier about. I think through med school, I felt like I was told a lot by professors or, conversations with my friends, like, oh, I want to do something with a lot of variety, a lot of generalizability. Like, you're seeing tons and tons and tons of different stuff every day. And I thought that's what I wanted, and I thought that was a good thing. But for me, when I compared plastics to vascular, the one thing that really stood out to me was that, plastics is very general. They're working everywhere. Like, they're very specific. It's plastic surgery. But they're doing all kinds of stuff. They're doing burns, flap reconstruction, cosmetics, craniofacial stuff. Like, there's so much stuff going on. Whereas in vascular, it was just a bit more specified and a bit more of a narrow focus for me, but still a ton of variety anatomically. You're working all over the body. You're in the abdomen, you're in the neck, you're on the toes, you're in the legs. So lots of variety anatomically, but surgical technique-wise and sort of a little bit more pathology-wise, a bit more narrowed. And at the end of the day, that's just what suited me better and what I wanted to do and where I saw my life going. And I also thought a lot about, what kind of stuff do I want to get called for when I'm on call as the staff?
Yeah.
And a ruptured aneurysm is pretty exciting, or an acutely ischemic limb is pretty exciting. And you know that when you're getting that call, you're going in the hospital to operate to save someone's life or limb immediately. And that was really cool. So lots of discussions, but a lot of little things kind of added up to that big decision.
Right. And definitely kind of over the period of clerkship, getting more experience seems like was really helpful.
Yeah, absolutely. You learn so much about yourself during clerkship, and it's such an important year. Like, I just cannot stress that enough. It's so important to take all the experiences, as best you can.
Right. Do you have any advice on the best way to approach clerkship then? Given that it's such a, important year in the whole decision-making process and something that personally it's coming up for us in just over a year. So
this is like my favorite topic.
Great.
My favorite topic. I think so. Like I just said, clerkship is not only is it such an important year because you're learning about everything in medicine, but it's such a special opportunity and such a remarkable year. Like, never in your life will you get to be exposed to so many facets of medicine and surgery and everything with pretty much no responsibility and very, very few expectations. The point of you going through clerkship is to be exposed to as much as you can, soak up as much as you can as a sponge, and just learn what you want and what makes you happy. And there's, you're part of a team, and you have lots of direct patient exposure, but not a ton of direct responsibility. Sure, you'll be given tasks because you're part of the team, but the expectations and the responsibility is quite low as a clerk. Something I did not know. I was terrified to be a clerk, but now as a resident looking back on it, I can see the differences. So I think my advice for clerkship is just try your hardest to just let go of those anxieties and those jitters before the new, the start of clerkship or the start of a new rotation. I mean, it's easier said than done. I had them every single time and my anxiety basically consumed me.
Of course.
But if I had to go back and do it all again, I would just try my hardest to really put those to rest, because what every staff and every resident wants you to get out of clerkship is to enjoy yourself, experience the rotation you're on and what it has to offer, and put yourself in the future. Really look at that rotation, say, is this what I want to do? Is this what I love? In the good times and the bad, because you will have both on all rotations, and just take, every experience and every opportunity you can, and just enjoy it. It's just such a special year, and a year you'll never have again. So really just enjoy it as much as you can, because it's such a great experience.
I wish this is one of those times where I wish it wasn't a radio show and like people could see that. I'm just smiling. That's wonderful advice.
Well, I'm happy to say it as I say it to everybody as often as I can.
Yeah, we'll just put it on loop.
Yeah, sure.
Anytime we're going to listen to this episode a year from now and kind of get fired up going into the first day of clerkship.
Oh, it's just the best. It's just the best year. And just, remember that, because you'll get the anxiety, and that's normal. I mean, it's totally normal. But just try your best to just have fun and just soak it all up.
Yeah, it's a pretty unique experience. So then clerkship finishes, you do your electives, and then there's the big daunting CARMS process that comes up. So did you personally only apply to vascular surgery for CARMS?
No, I didn't. This is such a great topic, you guys, such good questions. I applied to vascular as well as general surgery. I had pretty much I had dedicated myself to vascular by the time I got to fourth year for sure. But I was super concerned. The year prior to me, vascular was insanely competitive. And I was scared, as I think anybody would be. And vascular used to be a branch of general surgery. So it used to be, you could go through your 5 years of general surgery, finish that, and then do a 2-year fellowship in vascular. But then in the last decade or so, maybe just under the last 10 years in Canada and the States, vascular has become what they call a direct entry program.
Okay.
So you just do 5 years of vascular surgery and then you're done. However, there are still certain schools in Canada and in the States that take a vascular fellow after completing general surgery. So to kind of give myself sort of like a backdoor entry into vascular if need be, I also applied to general surgery in case the direct entry vascular didn't work out for me.
Right. That makes sense. And that's something that, isn't abundantly clear, at least after a year, of how all of the intricacies of the CARMS process end up working out.
Nothing's clear about CARMS.
No, it's all a black box. You just throw it in and hope it pumps out a match.
Best. Yeah. Yeah.
Do you know, this is maybe kind of a random question, but do you know if the process is a little bit different at all for the surgical specialties, or if there's maybe a bit of a different approach versus some of the medical specialties?
I don't know. I'm not sure. I think the process of CARMS is pretty much the same no matter what you're applying to, but don't quote me on that for sure. Yeah. I think maybe the difference is for some of the smaller subspecialties, maybe they might have more sort of focused or direct questions. And I would bet that the interview process is much different in the sense that when I had my interviews for vascular, every interview I had met the people on electives. I had met all the staff. So it wasn't it was still very daunting. Do not get me wrong. I was very stressed and anxious. But I at least had recognized the faces. I knew who the people were from electives. Yeah. Whereas on something much larger like family or internal medicine or maybe even gen surg, you might not know the person interviewing you just because there's so many people who apply and also so many people who work in that specialty. But I think the whole process of the application is probably similar across the board.
Right. And so with vascular then specifically, are they typically smaller programs in the school? Like, are there only a few vascular residents per year?
Yes. Yeah. And you'll see that with like the smaller subspecialties. They just take less people because the demand is typically less.
Right.
So speaking to vascular, I know in my year there was maybe 9 spots across the country.
Oh, wow.
Yeah, they only take 1 resident per program, except for U of T takes 2 residents.
Okay.
And not every school in Canada even has a vascular training program. And some of the schools in Canada that do have a vascular training program, they alternate between taking a direct entry 1 year and then the next year taking a general surgery fellow. So you kind of have to figure out how many seats are in your year based on what they took last year. And then, like I said, no schools east of Quebec have any direct entry training programs.
Right.
Yeah.
So it just adds to the black box.
It does. And for anything you do in CARMS, you have to do a bit of legwork. Like I did call a lot of programs and ask, because I couldn't find the information, I would just call and ask, was a fellow taken last year or is there a seat this year? And so you got to do a bit of legwork, but, you figure it out as you go along. Yeah.
I guess because it worked so well last time I asked this, I'm just curious, do you have any tidbits of advice for the CARMS process?
Make us feel great. Ever? I think CARMS is another thing. Obviously a high stress time, understandably. I can't think of a more stressful time in CARMS. You're choosing your career. It's terrifying. No questions. Yeah. But we all have to go through it and we all survive. My piece of advice, I think, the application itself, it's like on a website portal. And when you log in, there's like a whole bunch of demographic information you have to put in. You basically have to put in your entire CV into a new format. You have to reformat your whole CV, put that in. It's like there's just a ton of busy work at the beginning. So what I did is as soon as CARMS opened up the CARMS portal, I would just kind of get on that portal right away and just finish that busy work. That doesn't take any thinking. Like you don't have to think about anything. You're inputting your demographics and your address and all that crap.
Right.
Just, get all that stuff out of the way. And it opens up before your electives actually start. So you can get a pretty good leg up on that and just get it done before you're pretty stressed. And then the other sort of half of the CARMS application is your personal essays for each program you apply to. You write an essay basically answering the question, why do you want to go here and why do you want to do this program? And that for me, I'm a very weak writer. So that for me was my biggest source of stress because I'm not the greatest writer. Right. So I would just I started early, kind of had like a running Word document and kind of creating this, basis of an essay about why I want to do vascular surgery, because that can be applicable to all the essays. Right. And then the second paragraph or the second section of why this school, I would just change for each school. But every time I did an elective, I would try to jot something down. Like, I'm not saying writing in full sentences because I just didn't do that and I'm a little bit lazy. But just jotting down some things like, what stood out to the program. Was there a cool case I had during the program or my elective there, sorry. Was there something specific I liked? Just so I could, go back to it when I write the actual paragraph for that school. And also for the interviews, because sometimes in some of the interviews, they'll ask you, like, what did you enjoy about your time here? What did you not enjoy about your time here? Or what do you not like about our program? So just having some details just jotted down I found very helpful. But just having like a running Word document that I'm constantly adding to, I found quite quickly I was done kind of my draft one of most of my essays by the time I was, near my last elective. Oh, yeah. So it actually did take quite a bit of stress off me because I didn't have to do too much writing, as I had already had pieced together, some semblance of an essay. So that took some of the stress off of me. So I wasn't, at the finish line hurrying to finish these otherwise important essays.
Right.
Yeah, right. But it's hard. It's hard to do that.
No, of course.
I would do it on flights, like in between electives, because, during the days, waking up at some ungodly hour for rounds and coming home late and tired, there's no way I was going to work. There's just no way. So I usually did it on flights or on the ferry or something like that.
Well, that's a good idea.
So just to move away from the stress personified that is CARMS, and back to your decision on vascular surgery. One thing that we don't really hear a lot about during medical school, and something where the resources seem almost non-existent, is the job market of various specialties after you graduate your residency. Was that something that played into your decision at all? And how much of an impact should that have on the way that people choose?
That's such a good question. It didn't really play into my decision. I mean, you ask, as a med student, you totally ask. And I certainly asked residents too about what they thought the job market's like. But it's so hard to predict. It's just, it's almost impossible. I mean, best case scenario, you finish your 5-year residency and you get a job right away. But that's 5 years, and you have no idea how the job market's going to change, and you don't know what you're going to change, how you're going to change either. Maybe during your residency, you really enjoy one facet of that specialty, and you actually want to do a fellowship somewhere else. You don't have to, you just want to. So that's now 7 years. And in some situations, to get a job, you have to do a fellowship. So that's, again, 7 years. And how could anybody predict the job market and how it's going to change in 5 to 10 years? It's almost impossible. That being said, there is some historical data of various specialties that have been notoriously known to be difficult to get jobs in. But I don't know. I think it didn't play into my decision very much because at the end of the day, for me, it's more important to do what you love. And if it takes longer to get there, well, then so be it. But at least when I get there, I'll know that I'll be happy. And that was more worth it to me than choosing something that would have been easier to get a job, but I might not have been necessarily as fulfilled, because we all work super hard to achieve already what we have achieved and what we want to achieve. So I think it's important to focus on what's going to give you happiness in your career, because you work so hard for it. So you deserve that. But if, getting a job is really important to you, then, take that into consideration too. And there's no wrong answer. But I didn't take it into consideration for me.
Well, thank you for sharing those inspiring words. I'd just like to pedal back to your comments on third year and how you advise enjoying it because you have almost no responsibility. But as we all know, once you become a...
But I mean that in a nice way, not like a mean way. I feel like that could come off very mean.
You have no responsibility,
I don't mean
so
it like
just
that.
do whatever you want.
Do whatever you want.
But as we all know, once you become a resident, your responsibility dramatically ramps up. So how did you deal with this initial increase in responsibility?
Yeah, there's definitely a shift. However, I don't want to water this down, but less of a shift than I thought it would be, because you shift from 4th year med student to 1st year resident. And there's still a 2nd year resident ahead of you, a 3rd year resident ahead of you, a 4th, a 5th, and staff. So there's still a responsibility ladder. And people know you're a 1st year resident. But at the end of the day, if you're admitting somebody, no one's going to check over your admissions orders because you're a 1st year resident. That being said, if you're concerned about admissions orders or you have a question about the admissions orders, no one will ever fault you for asking for help or asking to look over them. So I think the responsibility change kind of comes a little bit on you to have the sort of insight and self-awareness to know when to ask for help. Because I think there's this conceived notion that, oh, I'm a resident, I should know what I'm doing, and I should know the dose of this medication, or I should know how to manage this. But I don't really think anybody expects that, especially in first year. Maybe when you get higher up in residency, that changes. But I think in first year, people who work above you and people who work with you expect you to know how to be safe. And I think that's the biggest responsibility shift is you are a little bit more independent, but you still need to know when to be safe and, when it's appropriate to ask for help. And when's appropriate just to be like, oh, you know what, it's just a dose of Tylenol. I feel like I can probably just look it up instead of asking my staff for what's the dose of Tylenol, just kind of reading the room. But at the end of the day, you have more independence as a first-year resident, but it's slow. Like, your first day, you're not going to feel as confident as you will your last day of first-year residency, and everybody knows that. So I think, there's a responsibility change, but it's about being safe and knowing when to ask for help. I think that's one of the biggest things that stood out to me.
Mm-hmm. Well, thank you for sharing the background of your transition. Could you now tell us what the day-to-day of a vascular surgeon resident is like?
Yeah, totally. So my day pre-COVID, things are a bit different now.
Let's talk about general non-pandemic day-to-days.
So the day-to-day, for us, most surgical specialties probably start rounds around 6 a.m. There's some variability in that, but for us, it starts around 6. So get to the hospital around 5:45, print out the lists, check up on any urgent things, get sort of the day organized. So rounds will go until around 7 o'clock or so. OR starts around 7:30. So that half-hour window is a good time to get food if you haven't gotten food, sort of get prepped for the OR, look at the scans if you haven't seen the scans. If there's small tasks to do on the ward, such as getting patients prepped for discharge or getting CT scans ordered or getting extra lab work ordered, getting all those sort of busy chores out of the way before the OR starts. And then getting down to the OR. ORs typically start around 7:30 or 8. Heading into the OR and just sort of talking to your fellow senior residents and sort of determining what you're going to do for the day, what the case is about. Usually there'll be a little bit of teaching somewhere in there, exposures or anatomy or pathologies. There's usually some kind of teaching before the OR starts, just kind of casual, nothing really, scheduled. And then it's just about spending the day in the OR if you're not on call and learning what you can and getting your hands in there as best you can. And then if you are on call, by the time the OR starts, there's usually a couple pages already, so it's a bit harder to get into the OR. It's more about managing the pagers, seeing consults, dividing up tasks, and getting the work done that comes as the day rolls by. And then once you can, if you're on call, escape to the OR as fast as possible, because that's where we all want to be at the end of the day. And then ORs at VGH at least end around 4:30. And then after that, we just sort of run the list as a team, see what chores were done in the morning, what has to be done still, what we need to check up on. That CT scan we ordered at 7 a.m., is it done? What did it show? What are we going to do next? What are we going to do about it? And just tidying up the ward and tidying up the things before the end of the day. And sometimes it's really nice. Sometimes we're out of there by 5 o'clock. Other days, you're getting pounded by consults. You have 2 people in the merge waiting. You got a patient being sent from clinic. You got somebody on the ward who's not doing so well. And sometimes the days can go a bit longer. So it's sort of hard to figure out when you're going to go home. But the seniors are really good about trying to get people who are not on call home by, around 5 or 6 o'clock.
So that's the day-to-day of an R1. How does it change throughout the 5 years?
So at least in our program, the more senior you get, sort of the less responsibility you take managing the ward. I think as an R1 and an R2, it's your job to get really proficient at managing the ward, managing sick patients, seeing sick patients, coming up with plans for sick patients, while the seniors are in the operating room getting better at their technique and their skill. So as you progress through residency, at least what I've seen so far, is the seniors spend more time in the operating room getting more hands-on training for the more intricate parts of the procedure, and less time doing sort of the nitty-gritty management, sort of scut work, if you will, that the juniors take care of.
So I want to ask what always seems to be one of the toughest questions to answer. Can you tell us what you like most about your residency, and more importantly, what you dislike most about the residency and the specialty?
Oh, that is actually a really tough question. Okay, yeah. It's almost impossible to tell you what I like about the residency because I like so much about it. I love the people, I love the patients, I love the procedures. Like, I love everything. I just genuinely really do enjoy going to work.
It seems like that's always how people describe their residency when we're doing this show.
Yeah, it's a lot of fun. Like, it's just so much fun. I think being so fresh and so new, it's still sometimes like I'm just so sort of surprised that I get to do this. Like, it's just amazing. I really do love everything about residency. Even the times that I feel like I'm having a bad day or I'm just sort of sick and tired of stuff. You'll just have one experience and you'll be in the OR and your hands are holding back someone's entire small bowel. And I just realized, like, oh my God, like, look at what I'm doing. Like, this is unbelievable. What a privilege. So I think I really do enjoy most aspects of residency, but obviously for me, I love being in the OR. Like, I really do. Even those long, tiresome cases, when you finish that case, like, it feels so good. And to know that, that patient came in with an ischemic limb or, stenosed carotid artery, and you fixed that. I mean, maybe not me directly because I was just suctioning, but, the staff who someday hopefully I become, fixed that. Like, that's unbelievable. So I love being in the OR. I just love it. But I love other aspects of it too. And then what I don't like about it, that's way harder to answer.
This gives people a rounded view on it.
No, it's true. I'm trying to think about what I don't like about vascular. Do you want something vascular specific?
It doesn't really matter. It could be specific, yeah, to like vascular or to surgery in general, because I think that's something that's also like sort of stigmatized against, so.
I mean, you're asking the wrong person because I'm very biased. I love surgery and all the bad things that come with it. I like it. Oh man, that's a tough question. You should have asked me this in advance so I could have prepared something. I don't know.
Yeah.
I guess, man, I would say like maybe the unpredictable nature of it. Like sometimes, but I know that's a bad answer because even when I'm not on call and a very exciting case comes in, I would rather stay to see that exciting case than go home.
Right.
But, sometimes I would suppose if you had made plans for something or you want to go do something and it's a bit unpredictable and maybe sometimes you feel like you should stay, maybe that wouldn't be great for some people. But for me, like I said, I would actually rather stay at work. So it's not what right. I don't really mind that aspect, but I think some people would not like that aspect of it. Is surgery can sometimes be much more unpredictable than other fields of medicine for sure. And cases can go wrong and you can be stuck there way longer than you anticipate for, anything.
And yeah, a lot of the time you're going to have to put these surgeries before everything else.
Yeah, you do. You do at the end of the day, because if somebody needs an urgent surgery, you got to deal with that. You got to be there.
So that leads really well into what I'd like to talk about next, which is just this sort of stigma around surgical residencies among medical students. There's just this idea that they're totally life-consuming, brutally difficult, and maybe even host to a toxic culture. Have you had any experiences with these stereotypes, or are they just that, stereotypes?
Yeah, I mean, we've all heard those. I've heard those. Everyone's heard those. You see them on TV all the time. I don't think that's really a big surprise. But for me personally, I have never once experienced that from an attending. I think people always have this idea that surgical attendings are going to yell at you or, be cruel or whatnot. And, there are certain attendings that maybe aren't as chatty as others, maybe not as warm as others, but you just see that and you just act appropriately. So, don't, talk as much in the OR and, ask appropriate questions, but don't start chatter or conversation. But I've personally never had, one of those bad stereotypical experiences. That being said, I do have friends who have, and I think, maybe they do exist still. But I would say confidently the rate of those happening is going down significantly. I think there's a huge push in the surgical culture now to really change that. A lot of residents love having learners. They really want that changed, and none of us believe that stigma. It is a different environment, but I mean, I had weird times on medicine too that I didn't really like, or had staff on, medicine that I didn't really like, and I had staff that I loved on medicine, and there was electives I had in surgery that, that surgeon has a temper, but it's not just because they're a surgeon. It's just who they are. But I never had anything direct to me necessarily, and I think that culture is starting to shift.
So working along a similar vein, for the people who never believe these myths in the first place and know they want to do surgery, do you have any advice for choosing a subspecialty of surgery that's right for them?
Yeah, totally. The answer is shadow. You just got to get out there. You have to expose yourself to as much as you can and as often as you can. Even small things like get a suture kit. Do you like suturing? Do you enjoy that? Obviously, no one's good at it when you're first starting to learn it, but do you like that challenge? But I think shadowing is super important. There's lots of things in the surgical world that I never shadowed, and I just never got exposure to. I've never seen an ENT case. I've never seen a urology case. There's lots of stuff I've never seen, despite shadowing quite a bit in first and second year and continuing to shadow throughout clerkship when I could. That being said, when I was in clerkship, I was shadowing more vascular because I was really kind of tossing up between plastics and vascular at that time. But you have to just expose yourself as much as you can. And I know, at least in vascular, we allow medical students to shadow residents and staff. So I don't know if that's the case for all other surgical specialties, but people are very happy to have med students come shadow. It's no problem. So just reaching out to staff and not being scared to email people that you don't know and get that exposure.
That's awesome. I think I'm going to look forward to shadowing when we're able to now.
Yes, hopefully COVID's kind of putting a...
hopefully soon, but bigger fish to fry on that front.
Yeah.
But that's I think that's a really useful thing for us to know moving forward, that it's really the only way you can get the exposure to some of those clinical settings, right?
Absolutely.
And, Aidan already called me out for never being in an OR before, but...
Sorry to do that to you.
maybe sometime soon.
And even if you think you don't like surgery, you can never see yourself in surgery, shadow it anyways. Yeah. Make sure, because you don't know. Make sure.
You have no idea. I'm curious so thinking about this, so again, never been in an OR. So the first time that you're actually involved in a surgery, I just think about like the first time you're either like obviously making a cut or like actually having your hand involved in a surgery. What was that like?
Yeah. Okay, I can remember two like early experiences. So the first time I scrubbed ever, I must have been within the first week or two of med school. Like it was super early. I was very keen to shadow surgery. And I had no idea what I was doing, obviously. And so this resident, she very nicely taught me how to scrub, and I was shadowing Gen Surg at St. Paul's. And I walked in, and my hands were like so awkwardly high up in the air. Like I was just so scared to touch anything. I was so terrified. And as soon as I opened the door, I touched the door and had to restart scrubbing all over again. And the scrub nurse like made it very obvious. She was like, "No, you just touched the door. Like go start again." So I was so embarrassed. Like nobody cares. Like nobody cared. So that was funny. And then the first time that I actually got to suture a human, I had practiced. I bought a suture kit like the day I got accepted to med school. Basically, I was super excited. So I had a little bit of skill. I'm not saying I was good by any means, but I was okay on my little practice foamy pad. And I was shadowing plastics, and one of the plastics resident let me close the skin. The last case of the day, and he's like, take your time. And the tremor I had was unlike anything you've ever seen before. It was just crazy. I was so shaky and so nervous, and I remember apologizing. I was like, "Oh my God, I'm so sorry. This is so embarrassing." It's like, you know what? It's okay. We all have a tremor. Even we have tremors as senior residents, and they go away with time, but it's nothing to be ashamed of. And he was just so kind and helpful, and taught me like little skills to minimize the tremor, and resting my hand on the table as opposed to holding it way up in the air, which is where it was. And I was so scared, but it's normal, right? It's a big first step, and you don't get to see the human body in the way that you do in the OR, and it's a totally new thing. So everyone was very happy and very nice about it.
Yeah, I imagine it was nice to kind of normalize that process too, because I'm sitting here like finishing my 20 ounces of coffee that I have a day and worrying about like how am I going to hold steady. But
I have tons of coffee every day. But I still get a tremor in the OR. Like if I'm doing something new or something I'm not entirely comfortable with, like I will notice a huge tremor. And, I've learned these little tricks along the way to minimize that, and it helps. And I see staff who have slight tremors too. It's not the end of the world. We're all human. Yeah. I think the difference is when you're attending or a senior resident, you just have so many years of practice under your belt. You can accommodate for it better, and it's not so new. Whereas when I have a tremor, it looks like I'm like there's an earthquake in my body. Like it's just crazy. So, but everyone's just so understanding, and it's a huge learning curve, and everyone's aware of that.
Right.
But it feels amazing.
Oh, I can imagine. Now I'm excited.
Yeah, good.
Yeah, exactly. And this is the whole point.
Yeah.
So one thing you mentioned a couple times are fellowships. And I know that's a little bit of a ways away for you, but I was just wondering if you could talk a little bit about what those are and how that works.
Yeah, I can give it a whirl. So fellowship is basically like more training in a more specialized area that you've already been trained in. Okay. So for example, general surgery has a ton of fellowships because general surgery, as it sounds, is very general. They have to know everything. They have to know trauma, they have to know breast, they have to know abdominal, they have to know everything general surgery does. So when you go through your 5-year residency of general surgery, if you want to do something specific and you just want your practice to be maybe colorectal surgery, dealing with colon cancers and colon removals and things like that, you're going to do a fellowship training just on colorectal surgery as opposed to doing trauma, as opposed to doing breast and sort of repeating all the things that fall under the huge umbrella of general surgery. It's just more training that's much more focused in a field of that specialty.
Right. Is that something you would consider doing in the future, or guys kind of see how the next number of years go?
Yeah, I mean, one thing that's nice about vascular is there's not actually too many fellowships within it. As I said a little bit earlier on, vascular is much more of a narrow field. So comparing it to plastics, for example, you can do a fellowship in all kinds of stuff in plastics. You can do hand, cosmetics, breast, lots of stuff, craniofacial, things like that. But in vascular, it's already a much more narrow field. So there's not a ton of fellowships for further training. Most of the fellowships that we have, from my understanding, and I haven't looked too much into this, but from what I understand, a lot of the fellowships are sort of more complex aortic stuff, so complex aortic reconstructions, large thoraco-abdominal aortic aneurysms, complex endovascular procedures, things a bit more next level. You could do a fellowship in. But vascular surgery, when you finish your 5 years residency, you kind of need to know everything that's in the specialty because it's kind of narrow enough. But some people later will change their practice to do maybe just veins and vein pathology, and that could be a fellowship. Whereas some people might tailor their practice a bit more to complex aortic stuff. But most of what I've seen, even the people that maybe do mainly complex aortic work still do the bread and butter of vascular surgery. They'll still do the carotid endarterectomies, they'll still do the ischemic limbs, but they just have an extra sort of facet to their practice that's even more, a little bit next level.
Right. So it's just a hyper specialization kind of thing.
Kind of. Yeah.
That makes sense. So one thing you've mentioned, so you finish residency, maybe do a fellowship, and then you become an attending surgeon. And you've mentioned this a little bit, but do you have an idea of what the lifestyle looks like for an attending vascular surgeon? I don't know for sure. Right.
But
we're jumping the gun a bit.
We're kind of jumping the gun, but just kind of based on what I saw in my electives as a fourth year, I think the lifestyle is a little bit dependent on where you work, at least for vascular surgery. And it kind of depends on how you want to do your practice. Like I was in certain sites on electives, and if, let's just say, surgeon A does surgery all that day but isn't on call, but one of their patients who had surgery that day needs to be taken back to the operating room, even if surgeon A isn't on call, they will still come back in and they will take their own patient back to the OR. Whereas I was on other electives where if you're not on call, you don't come in, even if it's your patient's post-op complication, you trust the vascular surgeon on call to fix that. They always will call the attending who did that surgery as a heads up or whatnot, and they can come if they want to come in. But I think for the most part, from what I saw, vascular surgeons will tend to come in for their own patient complications, like if it's a take back that day, but if it's multiple weeks later, not necessarily. Right. But I think the life of a staff surgeon in vascular surgery, I think it's okay lifestyle wise. Like I said, like the beauty of vascular is when you're on call, it's such a narrow field. Sometimes you don't get any calls at night, and I've had a couple call shifts even when I haven't had a single page overnight. But then there's other nights when, you know, stuff's going down and things are getting crazy. You, as the attending, you are coming in and you are doing life or limb surgery that night, no matter what it is. But that's an exciting feature. Like, I would much rather come into the hospital in the middle of the night as an attending knowing I'm going to do an absolute emergency procedure that night to save somebody's life or save somebody's limb, versus coming in as an attending and doing a surgery because I have to, not necessarily because it's urgent, just because I'm on call and I have to be there. So, you know, that's a nice aspect to it. But I think the lifestyle's okay. No matter what you do in surgery, you will always have certain times in your life when you're going to have to make a sacrifice. But that's, I think, no matter what, if you're in medicine, for the most part. It might be a bit different in surgery. Like I said, some of that unpredictable nature. But I think the lifestyle's okay. You just have to be willing to, you know, work around some of the unpredictable aspects.
Yeah, of course.
Well, Alexa, again, thank you so much for demystifying this specialty that
My pleasure.
is likely not on a lot of people's initial radar. Before we end, is there any general piece of advice you'd like to just give everybody?
Other than the tons of stuff I've already said on my soapbox.
We'll bring the soapbox back one last time. Third time's the charm.
Soapbox is important.
I would just say, well, first I just want to tell you guys, like, this is such a great project and such a great idea. So congratulations to you two for putting this out there. It's going to be so useful. I wish this existed when I was starting. But for all, you know, all the med students earlier on, like first year, second year, as I said already multiple times, shadow as much as you can. Even if you're convinced you don't want to do a merge, shadow it anyways and make sure you don't. And then coming into clerkship, be true to yourself, keep a very open mind, show up on time, have a good attitude, and just be willing to soak in as many experiences and opportunities as you can, because it's just such a wonderful year. And fourth year, everyone goes through CARMs. Everyone's going to be stressed and anxious, but we all do it. You have lots of support. You will get through it. You know, just manage your time as best you can.
Awesome. Well, I think we'll end it on that positive note. And that's it for our episode today. Thank you so much for joining us, Dr. Mordhorst.
Oh, thank you so much. Please call me Alexa.
Thank you for joining us, Alexa.
There we go.
Yeah. And good luck in all your future endeavors.
Thanks so much.
Thanks to you guys too.
And thank you for listening to Metamorphosis. You can check out more of our episodes on Spotify, Apple Podcasts, or wherever you get your podcasts.
This has been a presentation of the UBC Medicine Learning Network.